Okay, everyone, we can go ahead and get started. My name is Sophie Maria, and I am a consultant with Guidehouse supporting CDC's OneLab initiative. A couple of notes about the webinar before we dive in. If you're having any technical issues throughout, please feel free to email the OneLab inbox for support at onelab@cdc.gov. If you have questions throughout the session, insert them into the Q&A session at the very end of this presentation. That's when we will review questions and do our best to answer. Please note that I've posted the link to the live captions in the chat, but be sure to keep both the caption window open if you use it, in addition to this webinar. Today, we'll start by discussing some relevant OneLab resource. Then we'll go through some introductions. We'll have a 10-minute Q&A session at the end where we will review questions and do our best to answer them. And then today's session will end with a discussion of upcoming network events. For today's webinar, we will be leaving the chat feature open for your engagement. When utilizing the chat box, please keep in mind the appropriate rules of engagement. Feel free to use the chat to connect with others by reacting to what you're hearing, sharing experiences, and asking questions to fellow participants. If you have a question for the presenter, please use the Q&A function, not the chat. Additionally, please engage with respect and professionalism. Any form of discrimination, inappropriate language, or improper conduct may result in removal from the webinar. Please ensure your comments are relevant to the topic, and if a moderator gives direction regarding the chat behavior, please comply accordingly. Lastly, please notify moderators if you experience technical difficulties or observe any disruptive behavior. I will now turn it over to our OneLab Network lead, Alicia Branch, to share some of our new and relevant resources.
Thank you, Sophie. Before we begin the main presentation, I want to highlight today's relevant OneLab resource. It's the Introduction to Laboratory Risk Management e-learning course. This course provides an overview of the benefits of laboratory risk management, outlining processes and activities that emphasizes the importance of continuous improvement to reduce risk in the laboratory. You can find the link to the course in the chat. Next slide, please. Next, I'll read the PACE disclaimer and then introduce our speaker for today. Subject matter experts and presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Next slide. And I'm excited to introduce our presenter for today, Dr. Nancy Cornish. Dr. Cornish is a physician, pathologist, and clinical microbiologist. She earned a Bachelor of Art in Philosophy from the University of Vermont and her Doctor of Medicine degree, as well as completed her residency in clinical and anatomic pathology at the University of Vermont School of Medicine. She completed her fellowship in clinical microbiology at the Cleveland Clinic Foundation, where she later served as an acting director of the Department of Clinical Microbiology. She later served as the general pathologist and director of clinical microbiology at Nebraska Methodist Hospital in Omaha, Nebraska. Dr. Cornish serves as a medical officer and senior advisor for quality and safety in the Division of Laboratory Systems, specifically within the Quality and Safety Systems branch, where she has received several honors and awards for her dedicated work in improving quality and safety in clinical and public health laboratories. Our presenter for today is Dr. Nancy Cornish. Over to you, Nancy.
Hey, good morning, everybody. So the title of today's talk is Clinical Laboratory Biosafety Recommendations and Why We Should Follow Standard Precautions. I have a number of cautionary tales to share with you, which are true life stories. So we will get right into it. We have a viral hemorrhagic fever case. We had this last fall, and CDC got involved with the Iowa Department of Health to address the situation. And it was a patient with unsuspected viral hemorrhagic fever seen at 3 different institutions, and specimens were sent for testing to 3 additional institutions before the diagnosis of Lassa fever was suspected and then confirmed. So I want to remind everybody that we have no idea what's in our specimens in most cases. And this is how a specimen will come into your laboratory because it is unsuspected. People didn't know that this was what the patient had. So Lassa fever is a viral hemorrhagic fever endemic to Western Africa. And before 2024, there were 8 travel-associated cases that had been identified in the United States. So this is the 9th. And then the investigation that ensued identified 180 contacts in the health systems where the patient was seen. And this also includes laboratory professionals. So the Lassa fever virus testing was performed for 5 symptomatic contacts. And luckily, all the laboratory results were negative. So the link that I've included at the bottom of this slide is a link to the report that we produced. It came out in April 1st, I believe. So you can go and read about the case there. So we have 180 contacts. 96% were healthcare associated, and the remaining 4% were actually family and community contacts. What we decided to do was determine level of risk using personal protective equipment, and laboratorians were evaluated based on activities performed and the use of appropriate PPE. 34 contacts were identified across 6 laboratories where the specimen had been manipulated and tested, and 23 of these were classified as high risk and excluded from work for 21 days. This is based on published recommendations for biosafety in the microbiologic and biomedical laboratories, BMBL Appendix N. So we also have a link to the Appendix N, which is available, and I would highly recommend reading that. The exposures mainly occurred in the core laboratories, but molecular and other areas of the laboratory had gaps as well. So we had 105 high-risk contacts without contraindications who were offered oral ribavirin post-exposure prophylaxis. 5 contacts began prophylaxis, which is what they chose, and 4 stopped because of adverse reactions. One major adverse reaction of ribavirin is nausea. And 1 did complete the 10-day course. We had 158 contacts monitored for illness, and 5 had signs and symptoms potentially consistent with Lassa fever and were transported to a hospital under VHS or VHF precautions for evaluation and testing. All the testing results were negative. And I've included here 3 links that will take you to what Lassa fever is and how it presents, and then what we recommend, public health strategy and people with suspected or confirmed viral hemorrhagic fevers. So the Appendix N was written after the Ebola outbreak because we had such difficulty with laboratories not knowing exactly how to work with this organism. And so we also realized we had a lot of gaps. So the Biosafety, the BMBL has an Appendix N in it that is designed for clinical laboratories. This was published in 2020. And it was developed to address the clinical laboratory's needs as critical responders, which we are, and we are one of the first lines of public defense, public health defense. We need the safe and effective operation of clinical laboratories because it's critical for patients and laboratory professionals, the community, and the environment. So a few more cautionary tales. I'm going to start with a publication that was done after the Ebola outbreak by Andrew Bryan and co-authors. And the main point of this slide, which was shared with me by Dr. Mike Pentella and Iowa Public Health Lab, is that concentrating on the red and purple dots, this is where contamination due to droplets was found during this experiment. So what they did was they took hepatitis C and hepatitis B, I believe, and they ran specimens through their automated analyzer and then determined where they had droplet contamination. So you can see that it's quite extensive, and it's something that we need to be aware of when we're working with these analyzers and point of care tests or tests that you run on the bench. So this is another case that I was involved in when I was in practice. We had a technologist who was exposed to E. coli 0157H7 because she was running Shiga toxin testing. And she was doing it on the open bench, and she was not wearing PPE. And she became extremely sick and spent a couple of days in the hospital. And the public health lab compared the bacteria found in the patient to the bacteria found in the technologist, and they were the same. So you have to be careful. You have to think about how you're handling your specimens. And what was happening with this was she had the microtiter tray and she was banging it on the bench on a piece of absorbent paper. And we think that's probably how it spread. So droplet spread. Here's a couple other cautionary tales. Cryostats are used in the surgical pathology area to cut specimens, fresh tissues that come up from the OR. And so those tissues all may contain infectious agents that people are not aware of. So I've given you a list. They can have HIV in them, hepatitis B and C, tuberculosis, prion diseases, mycobacterial diseases of other types, systemic fungal diseases, viral hemorrhagic fevers. So I went and looked at all the package inserts to see what they recommended for PPE and how you would handle it. There were safety precautions. One was verify the potential of infectious diseases before handling the specimens. And then there was a little asterisk, and it said, this may not be possible or timely. And I think that's where one of our issues is. If the surgeon or the clinician has no idea what the patient has, they're not going to be able to notify you of that. And I really think that's probably more the rule than it is, the occurrence. Okay. People come into the hospital because people don't know what they have, right? They're coming in there to get diagnosed. So we're not able to actually determine on most cases what infectious disease that might have as when we get the sample. The other issue with cryostats is they have freezing sprays, and when you spray the tissue, it can aerosolize small particles of tissue. So when I went and reviewed the package inserts, there was not a whole lot of guidance about what kind of PPE you would need to wear. And what we decided was people needed to wear masks and they needed to wear gloves and they needed to wear eye protection and whatever else they wanted to add, but they really needed to protect their eyes, nose, mouth, and hands. After we instituted this policy, we had a pathologist who developed TB. And it turned out that the pathologist was cutting a specimen on the cryostat, and unbeknownst to the pathologist, the patient had tuberculosis. And so the pathologist got tuberculosis and was not wearing the appropriate PPE when they were cutting the specimen. So that's an example of, a direct issue that we have to be aware of, okay? We also have had another pathologist who developed prion disease and had been a pathologist for quite some time. And, before pathologists were aware of wearing masks and glasses and gloves and taking great care with cutting the specimens, the thought is that he might have developed this from cutting a brain biopsy. So I'm telling you guys this because I want you to think about it as you do your risk assessments, so that you can keep everybody in the laboratory safe. So I'm also going to show you a surgical pathology grossing station in case you haven't seen one of these. This is a pretty high-tech one. We often worked just in a box, like a glove box type thing. The main purpose for these is to keep the formalin away from you, because formalin fumes are not good for humans. It is not to protect you from splashes and droplet contamination. And often you may be working with fixed tissues, but you're also working with fresh tissues as you get them ready for fixation. So when you're working in one of these, you need to wear full bore PPE. So risk assessment is key in the clinical laboratories. And what we have done to address a lot of the concerns is we have developed a lot of training videos and PDFs to help people learn about this. This is a schematic on how to conduct a risk assessment, and I think it really helps to think about it as what you would do when you're crossing a street, right, or riding a bicycle, because you're making risk assessments every day on what the hazards are, right? You define the situation, you look both ways, hopefully, before you cross the street. You decide, okay, how fast is that car coming towards me? Do I have, the time to get across the street before it hits me? And that kind of thing. And bicycles are the same way. So you define the potential risks and then you make a decision, okay? Let's see. So we have designed risk assessment resources to help you out with this. And they're fun to go through, and they can also be used for helping people develop competency and feel comfortable with this kind of thing. So the other thing we have to think about in the laboratory is biosafety considerations. And elimination and substitution are not possible. So NIOSH has included that in their triangle, right? But that's really thinking about if you're doing research, for example. And that is the real difference in the BMBL and the NIOSH triangle, is that addresses research. It doesn't address clinical laboratories, which have really different issues. So what we've done is we've said, okay, where we need to start is with engineering controls to reduce the hazards and provide barriers, right? You can use biosafety cabinets, but we know that lots of laboratories may have only one biosafety cabinet or no biosafety cabinet. So what do we do about that? Okay, we can use splash shields. We can use full face masks. So that is something to think about as you go through your risk assessment and how you're going to keep the blood and body fluids away from yourself, okay? There's also administrative controls you can use. You can do training, you can do changes to work practices, you can write standard operating procedures that take this into account and educate people. Personal protective equipment, even though it's last on the NIOSH triangle, is one of the first things we do in the clinical laboratory. And especially in anatomic pathology, there's really no way to do an autopsy, for example, without wearing personal protective equipment, or do surgical sections without wearing personal protective equipment. And then one of the things we don't think so much about is waste management. We need to be very careful with that too. So Dr. Pantella shared a story with me where he was in the laboratory and he realized that they had large open cardboard boxes lined with biohazard bags, but they were throwing the specimens into those boxes, and there could have been a possibility for droplet contamination. And I have to say that I've seen that in my practice as well. So mitigation resources were defined in Appendix N. Engineering controls to reduce hazardous conditions. So get a barrier between the professional and the hazard. Barriers used in microbiology, for example, are class 2 biosafety cabinets. But think about sharps containers, right? That's also a barrier. Centrifuge safety cups, removable rotors, splash shields. So we use splash shields a lot. And then you work behind the splash shield. And that is very helpful, especially when you're doing blood culture bottles, for example. When you're taking your needle and putting it through the top to remove the blood, there is a droplet hazard there. So you do that behind a splash shield. Also directional inward airflow into the laboratory, so negative airflow, and closed automation systems are ideal, but we know that all of the automation systems are not closed. When engineering controls are not possible, you need to use alternative containment devices. You can do enclosed workstations in combination with additional work practice and/or enhanced PPE, just like we do in anatomic pathology. So we also have, after the Ebola outbreak, we realized that we didn't have any freely accessible biosafety cabinet resources, so we have developed that. And we have that as virtual reality as well. So the virtual reality, well, we'll go through the mitigation resources first. So things that are mentioned are active medical surveillance programs. So that's your occupational health or employee health. If you have a needle stick or get cut by a scalpel, you would go and discuss it with them. They will help you with that. Immunizations, we're very lucky now to have hepatitis B immunizations and Neisseria meningitidis immunizations, because those were two hazards to laboratory professionals. And then we have written standard operating procedures. And then work practice controls, frequent hand washing, safer sharps. We have self-sheathing needles and needleless systems now. And we always routinely decontaminate work surfaces. We use biosafety cabinets appropriately. We have training on that. And then we also have training on PPE, using PPE. And then you want to routinely protect your eyes, nose, and mouth when working with blood and body fluids. And that occurs in core lab too. You're uncapping tubes, you're putting, you're aspirating things with needles, you're loading them onto your automated system. And you saw the documentation of where all the droplet contamination happens with one automated system. So we need to think about that. Now this is fun. We have OneLab Reach virtual reality sources, and I've actually done this. I need to practice more. But we have a 50,000 square foot virtual laboratory created for clinical and public health laboratory training. And there's over 100 plus pieces of equipment in there and 10 to 15 minute training scenarios. So I encourage you to go and try it. It is kind of fun, but it's very different than actually being in a real laboratory, but it looks like a real laboratory. It does require a headset to be able to do it. However, I hear the kids have these headsets, so you could borrow one from your kids. We have trainings for donning and doffing personal protective equipment, and we have trainings for fundamentals of the personal protective equipment, fundamentals of bloodborne pathogens and laboratory safety, and then the general link, which is at the bottom of this slide, will take you to all of the things that we've done in biosafety so far. And we would really encourage you to submit what else you'd like to see, what else would help you in clinical practice so that we can work on providing that for you. Here are our trainings on waste management. And we do have a OneLab virtual reality packing and shipping of dangerous goods. So that'll be fun to give a try. We also have an echo session. So we have a series of echo sessions where experts talk with us about how they handle different topics. And this one is on waste management and how to handle it. So if I haven't convinced you yet that you should be wearing your PPE and doing risk assessments in the core lab and hematology and anywhere else you handle specimens, I'm going to take you through a number of studies that have been done. So Mycobacterium tuberculosis, laboratory personnel were 3 to 9 times more likely than the general population to get infected. All right, and that was published in 1957. So you can say, well, TB was more common then. But I've given you an example of somebody who got TB in the present day. And pathologists, it's well known that pathologists are much more likely to be PPD positive than the routine population. Hepatitis B was the most frequently laboratory-acquired viral infection, 2 to 4 times that of the general population. And the person who published this study in 1995 said any laboratorian who collects or handles tubes of blood is vulnerable. So I'm glad we have an immunization for this now. But if they were getting hepatitis B at this rate, imagine what else they're being exposed to. Neisseria meningitidis also is higher in microbiologists. Laboratory microbiologists were 20 times more likely to get the disease than the general population. And one of the reasons for that is when you're growing that on a plate, your colony has 10 to the 5th organisms per colony. So it's a very high rate of Neisseria meningitidis organisms there. So hot looping, handling it on the bench, really need to be in a hood for that. So in general, back in 1979, they did studies where they could not find any distinguishable exposure events identified in approximately 80% of the laboratory-acquired infections that were reported. In a 2005 study, 50% of the laboratory-acquired infections had no apparent source. So it's getting closer to present day. In many cases, the only association was that the infected person worked with a microbiologic agent or was in the vicinity of a person handling a microbiologic agent. So the data suggests that unsuspected infectious aerosols can play a large part in laboratory-acquired infections. And then if you need a little more convincing, we'll go to 2021. And the Federal Select Agent Program monitors occupational exposures to 68 select agents. Submitted reports from clinical laboratories in 2021, there were 103 reports and 102 reports associated with work outside primary containment. There were 551 exposures that resulted. Root causes included not following training on existing policy and lack of cross-communication with providers. And as we've said, many times providers have no idea that the patient has these kinds of diseases. So this was given at our Biosafety Town Hall, and you can go to the town hall and watch it. And there's a transcript, and it is a series of laboratory experts talking about gaps and what we need to do to address them in the laboratory. Now, this is an article or a MMWR by Miller et al., which if you haven't read it, I highly recommend it. And they went through all the areas of the laboratory and where the injuries were occurring. So in the chemistry laboratory or core laboratory, we had needle punctures, glass cuts, splash in the eyes, bruises and cuts, and we had the same issues in specimen processing areas. So needle puncture in 103 cases is not a small amount. Glass cuts, 44 cases, splashes in the eyes, 19 cases. Wearing PPE is important because you have no idea which of those specimens might have something in it you do not want to get. Hematology laboratory injuries, exposures to blood and body fluids, needle sticks, aerosols from centrifuges, removal of tube stoppers, tube breakage, contaminated gloves. And then other areas of the laboratory where you need to evaluate what's going on and watch how people are handling specimens, specimen processing, blood bank, immunology testing, and microbiology. So risk factors for laboratory personnel. Who's at risk? Anyone who handles blood and body fluids. And you may not see those droplets, but I can promise you they're there. And the reason that I know this is because I worked in autopsy and surgical pathology, and I always wore a mask and I always wore a full face shield. And when a droplet flies at you and you're wearing a full face shield, you can see it hit the shield. Okay, so that was a everyday reminder to me that you absolutely needed to wear your PPE. So aerosols and droplets can be generated from most routine laboratory procedures and are often undetectable. And I hope I've convinced you of that. You need to be careful when you're aspirating and transferring body fluids, when you're expelling that last drop from a pipette. And that includes all types of pipettes. When you're doing centrifugation, withdrawing needles from stoppers, removing stoppers from tubes, pouring, splitting, or decanting liquid specimens, and preparing smears, performing heat fixing, and staining slides. So we did have a person, a technologist working in microbiology one night, and she was withdrawing blood from blood culture bottle, and we found out the next day that it had Neisseria meningitidis in it. So we were lucky. We got her on antibiotics, but that these things happen, so you want to be careful right up front. So national safety standards. Properly maintained BSCs, so blood culture cabinets, other appropriate personal protective equipment, other physical containment devices to be used whenever procedures with a potential for creating infectious aerosols or splashes are conducted. And that's in the BMBL, and that's biosafety level 2. So OSHA does have a regulation for bloodborne pathogens, and I've given you the link, which will take you to the page that explains the differences between bloodborne pathogen guidelines, standard precautions, and transmission-based precautions. So in 1996, CDC went a step beyond bloodborne precautions and said to protect healthcare workers from pathogens in human blood and body fluids, and also pathogens present in other body fluids. Standard precautions includes hand hygiene, use of certain types of PPE based on anticipated exposure, safe injection practices, and safe management of contaminated equipment and other items in the patient environment. But standard precautions applies to all patients and their specimens, even when they are not known or suspected to be infectious. OSHA has a proposed rule, and it's gone through the proposed rule process. It is 1218, and the title is Infectious Disease Standard, and it is a supplement with for standard precautions with transmission-based precautions. It has not become a rule yet, but it is proposed, and it was started in 2016 after the Ebola outbreak, because the OSHA realized that we needed more protection and more standards around infectious disease in healthcare situations. And I will point out that Zika, for example, is found in high levels of urine. Now, there's never been a documented transmission of somebody getting Zika from urine, but we really have to be careful with all body fluids and blood because the next infection is coming down the pike, and they all have different characteristics. And we may not know what those characteristics are, but we can protect ourselves by following standard precautions and transmission-based precautions. So for anatomic pathology, we use engineering controls and PPE, and there's really no solution that I can think of at this point where you don't need to do that. You cannot work up all specimens in a biosafety cabinet, and you certainly can't do an autopsy in a biosafety cabinet. So ventilation of rooms, we have negative pressure rooms with at least 12 air changes per hour, adequate lighting, surfaces that are easily disinfected, only a minimum number of staff that's needed, and appropriate PPE. So we wear more PPE than a surgeon does when they're doing surgery. We wear our scrub suits, we have head covers and bonnets, long sleeve fluid resistant gowns and an apron, 2 pairs of gloves to cover the cuffs, face shield preferably, or goggles, mask or N95 or a PAPR, and booties to cover shoes, leg covers, or you can wear tall boots as well. And that's from the WHO guidelines. So stay safe and thank you. Back to you, Alicia.
Thank you, Nancy. We'll take a few minutes to answer as many questions as we can. If we do not get to your question, please feel free to email it to OneLab@CDC, and we'll get back to you via email as soon as possible. It's okay. This is a good one. So someone wants to know, how would you decide if you have a laboratory-acquired infection? Do you do routine checkups or you just wait for symptoms?
I think, first of all, there has to be some indication that the patient's specimen had something in it, right? Otherwise, you're not going to know. So what happened in the Lassa fever case was they did finally figure out that the patient had Lassa fever. Then they did a look back. So the Iowa Department of Health was involved, the laboratories and hospitals were involved, infection control and prevention at each of those hospitals. And they went back and they figured out who had actually handled the specimen or handled the patient. And that's a lot of work. It took a lot of time, but they were efficient and they were working basically 24/7 to document all this. It costs a lot of money too. So that's another thing to point out. It's very expensive to do all this work. And so there will be a cost analysis that's being done around this particular Lassa fever case to educate people on, that prevention is a lot better than trying to go back and fix it afterwards. But no, you have to know that the patient had something, right? And then you investigate it. And one of the issues we have is we often never know that. So that's why you need to be very careful and do prevention right up front.
Okay. Here's another good one. How should PPE and safety practice be handled when people have their actual working desk inside of the laboratory space?
Well, you'll have to do a risk assessment, won't you? So think of surgical pathology, all right? We had working desks inside the surgical pathology suite. We had to, right? And so what we wound up doing was actually doing an evaluation. And one of the risks we found was we had paper requisitions coming up from the surgery suites, and they would have blood on them. Okay. So we're like, how do we deal with this? What we wound up doing was the minute the surgical requisition came up, we put it into a plastic folder because we couldn't get the blood off it. We couldn't throw away the requisition, but we could keep that blood away from us. So that's how we chose to handle it. And of course, we did not eat or drink in the surgical pathology suite. So that's one example. So you're going to have to go in there, you're going to have to figure out where your risks are, and then you're going to need to mitigate them. Do you want to share where you think the risks might be?
We can have the participants put what they think where the risk would be in the chat.
Yeah.
Here's another good one. Someone wants to know, how do you explain the pathologist needing more PPE than a surgeon?
I trained for 1.5 years in surgery. We wore lots of PPE. And I'm not sure that we wore more than what you wear when you're doing an autopsy. We had scrubs, we wore a full bore fluid resistant gown. We often would wear an apron if we felt more comfortable doing that. We were double gloved. We had booties on. We wore bonnets. We had face masks. and, you know, shields, face shields too. So we stayed pretty safe.
Let's see. Well, someone was asking about if we had any checklists when doing a risk assessment, and I think the best answer for you is to look at the resources that were provided during the presentation. They're all great, and I would also like to share. We do have a risk assessment course that is coming out in probably the next few months, so be on the lookout for that as well.
I guess I would like to add something to the surgical question too.
Okay, go ahead.
Yeah. So in surgery, the main goal was to keep your body scurf, which we're all surrounded with. Just think about Pigpen, right? We are all surrounded by a little cloud of skin flakes and hair and stuff like that that we just transmit, right? So in surgery, the whole goal was to keep that away from the patient. And we really thought about it that way. So we were fully gowned and gloved and all that to keep the body scurf away from the patient, any kind of foreign bacteria away from the patient. But it also protected us. And it depended on what kind of surgery you were doing. If you were doing an abdominal surgery or a heart surgery or a dissected aortic aneurysm, there was blood everywhere. In training, we didn't think so much about protecting ourselves from the patient. We thought more about protecting the patient from us. But it worked both ways, right?
Right.
Yep.
So someone wants to know, what is your thought of having personal fans in the lab area, the laboratory area? They do STI testing on the benchtop.
Okay, so I will give you my personal opinion. This does not reflect CDC. Is I would not do it because, as we have just talked about, droplet and aerosols are often undetected. You certainly don't want to be blowing them towards yourself, right?
Right.
Yeah, I wouldn't want to do that.
Well, I say thank you again, Nancy. That's all the time we have to answer questions. Again, I'll say for those questions that we didn't answer, please feel free to email them to us, and we'll do our best to answer them. That's at onelab@cdc.gov. And if you have any questions about the BMBL, please email labqualitysafety@cdc.gov. And if you have any laboratory biosafety questions, feel free to email them to dlsinquiries@cdc.gov. And the links to both have been provided in the chat. We are offering one PACE credit for today's webinar. PACE certificates are available on our OneLab Reach in your My Learning Hub for easy access. So to receive your PACE credit after participating in today's session, you just need to log into your OneLab Reach account. And you can visit that link in the chat and then use the passcode to complete the evaluation within 2 weeks. Please remember, you must be logged into your OneLab Reach account to access the evaluation. So if you missed the links and passcode during this event, you will receive an email with these instructions. Next slide, please. So I wanted to highlight the September OneLab Network event scheduled for September 24th at 2 p.m. Eastern Standard Time. This event is entitled Introduction to Laboratory Director University. It'll be presented by by Ms. Cheryl Doby from the Center of Medicare and Medicaid. She'll provide a brief overview of the Laboratory Director University curriculum that's currently being developed by CMS and CDC. It's a self-paced e-learning course program for laboratory directors and training to address CLIA deficiencies. The registration and links will be available soon. And as a reminder, the slides and audio of this event will be posted in the OneLab Network past events webpage within the next 2 weeks. And as always, we encourage everyone to use the OneLab inbox to share your training needs and provide feedback about OneLab. That includes about our OneLab events, because we actually used your input to select our event topics, and it helps us to better understand the community's training needs. So the OneLab email address is posted in the chat for easy access. And again, we thank you and have a great rest of your day.